Welcome to the First Fill podcast, created by members for members. I'm Katie Meyer, VP of Education at APhA. I'm delighted to announce that we're relaunching the First Fill podcast as a members-only offering created by the members. This series is designed to showcase the expertise, creativity, innovation, and real-world experiences of members of APHA's communities. Each episode is designed to spotlight APhA members with the goal of delivering timely, relevant education for our listeners. APhA members have the opportunity to serve as a guest to showcase their innovation, and only APhA members can earn CPE for listening. In this episode, we are featuring a member from our Transitions of Care community, Marissa Cavaretta. Marissa will discuss how inpatient pharmacists can optimize discharge management to improve patient outcomes during transitions of care. Before we dive in, let me introduce my guest today. Marissa, why don't you introduce yourself?
Hi, Katie. Thanks so much for having me. I'm excited to be here and doing this podcast. As mentioned, I'm Marissa Cavaretta. I'm a clinical associate professor and the director of experiential education at Temple University School of Pharmacy in Philadelphia, PA. I've actually been on faculty for 13 years now. I'm also a practicing internal medicine pharmacist at Temple University Hospital, and a lot of my work focuses on transitions of care, or lovingly called TOC. And in this role, I help to ensure that patients have safe, effective medications as they move between these high-risk care settings. And I'm looking forward to talking about that today.
Awesome. Thanks so much, Marissa, for that introduction. So why don't we dive in here? So tell listeners, you alluded to kind of some of your roles and responsibilities, but tell listeners a little bit more about the work you do in your practice and give some examples of services that pharmacists practicing in an inpatient setting can provide to improve patient outcomes during transitions of care.
Sure. Well, as mentioned, I'm an inpatient pharmacist, and I currently co-manage a transitions of care consult service with a colleague who is full-time at the hospital. So he's a clinical specialist in internal medicine. And this is a service that I co-created about 5 years ago. Prior to that, I was an inpatient rounding pharmacist, and I would perform transitions of care activities on my patients, but our service would max out at about 18 patients. So I was limited in who I could provide those services to. So about 6 years ago, a colleague of mine and I, we decided that we wanted to start a service that was consult-based. And in fact, at that time, this was the first pharmacist-led consult service in the hospital. And the reason for it was to expand TOC services or allow for other subspecialties or providers to put in these orders and have their patients receive transitions of care services from us. Because we felt that in our services, which were limited, that we weren't hitting the highest risk patients across the hospital. So when we set this up, we developed a policy and procedures that allowed for providers to put in a consult order in our electronic health record system. And then we would get alerts of these patients, and they would come up on a list for us. And then we would see the patients and provide typical transitions of care services. So this includes best practice medication histories, medication reconciliation, discharge counseling. We work with our outpatient pharmacy to reduce financial barriers for these patients. We work with the providers to optimize medication regimens on discharge for guideline-directed medication therapies, and communicate discharge medication plans to skilled nursing facilities in addition. So those are the top services that we provide. And then, of course, we're always on call for questions and to help out with other things as needed once we've been consulted. So we have this consult service, and which is unique. But in addition, we have a number of pharmacists who have their own services where they do provide some transitions of care service on those. So we have pharmacists in the ED, we have pharmacists in the ICU, for instance, and some even on the general medicine floor that are incorporating these activities into their general workflow. But it is a portion of it, whereas we dedicate 100% of our time on service to these activities. Now, I want to go back to what's so unique about it is that it is referral or consult based. So the provider determines which patients would benefit the most from the services in that case. So it has allowed us to have that broader reach and allowed us to be able to care for what we consider some of the higher risk patients. So our service does tend to see patients who are readmitted quite a bit, who come in because of an adverse drug event, who have social determinants of health that are barriers to the care. So we do see some pretty sick patients, and the service selects for that because of the nature of it. In general, the reason why we focus and why when we wrote the procedures and the policy for the service, we focus so much on the services that I mentioned earlier, the medication reconciliation, the discharge counseling, the medication histories, optimizing guideline-directed medication therapies. We focus so much on that because we do know that readmissions are high. So an alarming statistic is that 1 in 5 Medicare beneficiaries are readmitted within 30 days. And our hospital has a very high Medicaid and Medicare population. So we have a decently high readmission rate. So the hope was that this service would help to reduce that in the most vulnerable patients. Overall, what we do know and we've seen in literature is that medication reconciliation that's performed by a pharmacist, a pharmacy technician, a pharmacy student, they're proven to reduce medication errors and potential adverse drug events upon discharge. Even discharge counseling services have been shown to reduce adverse medication events post-discharge. And we also know that these services are essential because the highest risk of readmission is within 2 days of discharge, whereas the highest rates are within 1 week. So we really make it a point to see these patients and have a couple of touch points with them before they leave, knowing that this is the case. Several years ago, we were performing post-discharge phone calls because independently, that type of service has been shown to reduce emergency room department visits and adverse outcomes for medications. So we did do that in collaboration with our population health center several years ago. And that is still a service that the population health center continues. But that alone has actually helped to reduce adverse drug events, at least post-discharge. Together, all of these services, when we work with the multidisciplinary team, can help to reduce 30-day readmissions. But to be transparent, we have not seen that alone with our service in isolation.
Yeah, thanks. It's definitely fascinating work, very innovative in your thinking and your support of these patients. You mentioned that the model that you practice under is kind of a referral-based model, but I'm curious a bit more about, I guess, your recommendations for a pharmacist that's considering starting a similar service. Who exactly should they target with only limited time and resources in a single day? I can imagine some pharmacists could be up all night helping every single patient if they wanted, but how do we really refine who we should be targeting for these types of services?
So the needs are so great, and ideally every patient should receive these services and would benefit from these services. But we know that pharmacist staffing is so limited in transitions of care roles because there is a lot of financial barriers to being able to hire additional pharmacists or pharmacy extenders to perform these activities because they are time consuming. That's actually the number one barrier and the number one cited reason why pharmacists or pharmacy personnel will say, I cannot perform these medication reconciliations, or I don't have the time to go and see all of these patients for discharge education and so on. So we do know that there are barriers. As I mentioned before, at our institution, we do have other pharmacists that incorporate these activities in certain acute care settings. So in the emergency department and in the ICU and on some of the general medicine floors, we have pharmacists that will incorporate it in the workflow for their highest risk patients. So it is doable, but we are also a teaching hospital. So we rely a lot on pharmacy students and pharmacy residents to help us. And we use them as pharmacy extenders when they're on rotations with us to perform some of these activities. But I do want to reiterate that is a portion of their clinical practice and not necessarily something that they may be able to perform on every patient on their service. So when you're risk stratifying, look for patients that are highest risk. So the first place to start is to look for patients with a history of multiple readmissions in the past year, because those patients are likely to come back and be readmitted again. And reducing readmissions has a financial benefit for the institution. So the institution will be interested in reducing readmissions as well. In 2012, the hospital readmission reduction program was put into place by the Centers for Medicare and Medicaid Services. And this incentivized institutions to reduce preventable 30-day readmissions. And it was targeting certain diagnoses codes or certain conditions or procedures. And that included acute myocardial infarction, COPD, heart failure, pneumonia, coronary artery bypass graft surgery, total hip arthroplasty, and total knee arthroplasty. So when these patients have unplanned readmissions within 30 days of discharge, a payment reduction to the institution is applied. So that's why institutions are particularly interested in services that could help reduce this. In addition to that, or beyond that, I actually should say, is we have data that shows with Medicare beneficiaries, the top 5 principal diagnoses where have the highest 30-day readmission risk include patients with septicemia, heart failure, acute renal failure, pneumonia, and diabetes with complications. And we see this too in our own institution. So that's another patient population that you could target to try to reduce those readmissions as well. In addition to that, there's several classes of medications that you see routinely linked in literature to emergency department visits because of adverse drug events. And oftentimes these are preventable in nature. And these include anticoagulants and hypoglycemic agents, particularly insulin. So targeting patients who are on those medications or newly prescribed those medications before discharge would be beneficial to ensure that they could take them safely and don't come back into the emergency department with an adverse drug event. In fact, even in your patients who have COPD, the risk for COPD exacerbation is actually quite high with inhaler misuse. And oftentimes patients get switched on and off their inhalers because of formulary changes. These patients are not educated on how to use the new inhaler. So by misusing the inhaler, they end up coming back with a COPD exacerbation. So that's another high-risk population. And then outside of medications and disease states, even if you look for patients who have certain social factors or social determinants of health, like not being insured, a lack of support in the home, food insecurity, unstable housing, a lack of transportation, these types of social factors also are barriers to being able to effectively take medications and care for oneself and could lead to more utilization of the hospital for care. So working together with a multidisciplinary team to try to help these patients and provide more services to them and more outreach to them could benefit those patients as well and keep them out of the hospital.
Thank you so much, Marissa, for that. The work you're doing and it's just certainly inspiring. So thank you very much for all that you do. All right. One more question for you today.
Yeah.
So because the work you're doing is so inspiring, I want to hear from you. What advice, so say there's a pharmacist out there that wants to start doing this or maybe expand their pharmacy service offerings that they're doing now in their practice. What advice would you have for that pharmacist who kind of wants to start or expand pharmacy services specifically related to transitions of care?
Well, I would say work with your administration to identify the most pressing needs of the institution. For instance, if your institution is accredited by the Joint Commission and they're looking to make sure that patients have medication reconciliations performed, then that's a targeted area that you could work with them. You could work with your administration in to identify ways to improve in that process. And it doesn't always have to fall on the pharmacist. You could train technicians and pharmacy residents and pharmacy students to perform these services as well. Look for those high-risk patient populations to target. Look to see which populations routinely get readmitted to your institution or routinely come into the emergency department and try to target either those high-risk diseases or even those high-risk medications, and then start developing lists or have automated lists come through your electronic health record system so that you can see those patients or provide special services for them before they leave the hospital. When resources are limited in general, just look for opportunities to integrate TUC into an existing workflow. And I'm going to give an example. In the last 5 years, we actually piloted 2 discharge order verification services. And we decided to target patients prescribed antimicrobials and diabetes medications upon discharge. So what we did, we worked with our bill team for the electronic health record software that we use. And we asked them to create a stop in the system for discharge orders. So meaning the prescriber would place a discharge order, and typically speaking, that discharge order gets electronically transmitted immediately to a community pharmacy. Well, in this case, that stop prevented it from going straight to a community pharmacy. And it stayed in the system until a pharmacist verified and reviewed the order. So if there was no issue with the order, a pharmacist would verify it, and then it would send to the community pharmacy. If there was a problem with the order, though, then it gave us a chance to reach out to the provider to correct whatever the drug-related problem was, and then they put a new order through, we would verify it, and then it would get transmitted to the community pharmacy. So this gave us an opportunity right before discharge to ensure that discharge prescriptions were accurate, that they were safe, and that they were appropriate for the patient before that prescription was transmitted to the community pharmacy. Because in the community pharmacy, those pharmacists don't have access to the patient's chart. They don't have access to the electronic health medical record system that we do. So we have insight to what was going on in the hospital and are better able to identify some of those drug-related problems or errors. Whereas in a community pharmacy, without access to that, you may miss it because you're just not aware of what the patient's labs were, for instance, or what the diagnosis was, or other medications that the patient may be on that they're not filling at your institution. So we found this to be really valuable. And when we did this with antimicrobials, the top intervention actually was relating to duration of therapy. We actually hypothesized that prescriptions were being filled with durations that were in excess of what guidelines would recommend. And that proved to be true. So our top intervention was actually reducing antibiotic duration. And then the second most common intervention with the antibiotics was actually dosing issues that we were able to intervene on. When we did this with diabetes medications, the top intervention that we actually made was correcting prescribing instructions. And this was actually eye-opening. I wouldn't have predicted this before we did it. But we saw a number of insulin orders and even insulin sliding scale orders that had no instructions, missing instructions, inaccurate instructions, or it would just say use as directed. And we felt that that was very unsafe for the patient. And many of these patients were never on insulin before. So this gave us an opportunity not only to correct the prescribing instructions and to make sure that they made sense for the patient, but it also told us which patients should we go and see before discharge so that we could educate them on how to use the insulin and go over the instructions with them as well. And then the second most common intervention for patients with diabetes who are being prescribed these anti-diabetic agents was to actually optimize therapy. So we found a lot of opportunity there to add a secondary agent based on their A1C or based on guidelines. We identified, a lot of need there as well. So overall, with that, the discharge verification queue, the lessons we learned there were that this could be incorporated into pharmacist workflow, but it does add additional responsibilities. So you have to be cognizant of that. And if you are going to go in that type of direction, then you might want to limit that service to times when the pharmacy department is fully staffed or when you have the highest volume of discharge prescriptions anticipated. Because what we did see is it could prolong discharge prescription transmission times to outpatient pharmacies, but the added value and the added service we found was invaluable.
Thank you so much, Marissa, for sharing your experiences and providing those tangible examples of how you helped improve transitions of care as a pharmacist practicing in the inpatient setting. I'm going to go ahead and summarize the discussion today. So first, some examples of pharmacy services that can be used to optimize medication management and reduce problems that transitions of care out of the hospital include conducting the best possible medication history at transition points, assisting with discharge planning, and providing discharge counseling services. Pharmacists should consider risk stratifying patients to determine who would benefit the most from their services. Risk stratification can include patients with a history of multiple readmissions in the past year, patients on high-risk medications like anticoagulants and insulin, and those who may be at risk for poor outcomes due to social factors that Marissa discussed. Pharmacists looking to expand services to support transitions of care should work with their institution to identify priorities and then think through ways that they can support and help them achieve those priorities. Integrating transition of care services into established workflows can ensure efficiency and help overcome resource-related implementation barriers, but it's going to take more time. So pharmacists should really strategically plan where to focus their efforts based on the goals and priorities of their institution. And that's all the time we have for today. In our next episode, I'll invite APhA member Tony Michienzi, who will discuss how community pharmacists can optimize discharge management to improve patient outcomes during transitions of care. APhA members, don't forget to visit the Learning Library at learn.pharmacist.com to earn CE credit for this month's podcast. Take care, and thanks so much for listening.
Of these patients.